How's the sound level?
Good. Okay.
And sort of a Goldilocks, not too loud, not too soft. So, all right. I really appreciate everybody coming out today. It's a great turnout. It's a subject that I feel passionately about. And I've entitled the talk, Holding Healthcare Accountable, How to Be an Evidence-Based Patient, or How Four Non-Blondes, a Leatherman, Phil Keggy, and coupons for overdiagnosed surrogate ashtrays will help you be healthier and fight inappropriate healthcare. And if you're wondering how that could be related, stay tuned. Next slide. So you heard a little bit about my training and practice experience. I've had the privilege of mentoring for several years now under the Canadian physician, Dr. Gordon Guyatt, who actually coined the term evidence-based medicine back in 1990. And that's been extremely helpful. I'm also a member of a 11-member state EVM committee. When I say EVM, I mean evidence-based medicine, which is called the Washington State Health Technology Clinical Committee, and we do reviews of different health technologies for recommendations for state-funded insurances. And then as you heard, I started EVM TIM in 2022 along with my colleagues Anna Collins, who's the head of the geriatric nurse practitioner program here in town, and Dave Krieger, who for many years was the head of the Yakima Heart Center. Next slide, please. I have no financial disclosures. I am fond of Monty Python-esque humor, as a number of you are well aware. Next. The number of resources, I think you have some of them, and then there are some articles as well on EMRs, that's electronic medical records, and provider burnout. I have some books that I forgot to set up. I wanted to give people a look at some of the resources directly. Next slide. And then somewhere I think I hope to have an EVM TIM sign-up sheet, and I'm not sure that I do. So the format here, we're going to fly through a lot of material, very difficult to distill these important concepts in an hour, but we're going to give it a shot, and a short break, and then a 30-minute question and answer. And I'm very gratified that I have some colleagues here from different fields of medicine and pharmacy to help offer their perspective as well. I think that'll be really flesh out these points. Next slide. This is self-explanatory. Next. Now that that has settled in. Next. So these next 5 slides do have relevance. We'll go through them quickly. Go ahead. Next. 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 And next slide. So what are my goals here? I want to ignite interest in the vital need for learning to become an evidence-based patient, or an EBP. We'll explain exactly what that is, or give you an idea of the direction it would go next. Provide some fundamental concepts and definitions and tools along with further resources to pursue your own study. And then third, next slide, I'd like to begin to offer some insight on how becoming an EBP will have a lot of benefits. Health promotion, a greater understanding of the system, balance and compassion for those who are really getting burned out in the system, compassion for other patients. And I have found that it has really helped balance my thinking and make me more cautious in what I'm saying. I tell people when I led the evidence-based medicine workshops here in town, when I introduced Dr. Guyatt, that studying under him has really helped me to say I don't know with a lot more confidence. And it's also going to give you more confidence, I would submit. And all of this is a process to bring accountability to healthcare. I'm not talking about animosity, but accountability to what constitutes good evidence and what the definition of health should be. Next, please. So the entire lecture, again, I'm into mnemonics. We go to lectures, oh, that was great, I can't remember a thing. And so one of the mnemonics, what the hey? The entire lecture can be summed up in 3 words: healthcare, accountable, and evidence-based. Next. And songs running through our heads, even if they drive us crazy, can also help. And there's a 1993 alternative rock song that can help with this. Oops. Well, that didn't work. Okay, next slide. And that's exactly what we're going to learn to do here, and that is to ask, what is going on with health and healthcare? Next slide. So language is everything. I can't emphasize this enough. A lot of what goes on in our daily lives, but particularly in healthcare, is related to imprecision and yet very strong emotive force in language. And so if we key in on that, and this is part of what has helped me, achieve more of a balance in these things. If we key in on that, we really are building on a good foundation. So next, this is one you have to click through a few times. So how would you define, click next, health, next, healthcare. So the health definition, next click. Optimal feeling and function for as long as possible. I would submit that that is a stab at a functional definition for health, not superlative feeling and function, not the highest that you could ever be, like the definition by the World Health Organization in 1947 would seem to push us to, but how are we define optimal feeling and function for as long as possible? What about defining healthcare? Very simply, I would say that it's the systems professedly designed to promote and preserve health. And I'm not speaking just of so-called conventional medicine, I'm speaking of any system more loosely or formally organized for that purpose. Next. Next. And how would you define next? Accountable. Go ahead. I would say that's simply responsible for doing something required or promised. Next. Go ahead. And last word, evidence-based. I would say evidence-based is an approach that emphasizes the need for and use of high-quality research, clinical research, to guide the care of the patient, seeking outcomes that are actually meaningful to the patient. That'll be a big emphasis. Next, please. Go ahead. So outcomes. This is a huge, huge, huge emphasis that needs to be there. To be truly evidence-based, as I discovered when I got into my more formal study of it, is really to focus on what are we looking at for outcomes and who or what defines them. The next one. And this is where language comes in. You'll often see words significant or statistically significant, clinically relevant, but really the one that's important is the one that's important. What's important to me? These may be true, clinically relevant and significant or statistically significant, but is there a real relevance to that? Next, please. So another critical distinction, how we feel or function as well as possible, as long as possible, versus a number or an abnormality not destined to harm, and yet that becomes a disease. As a critical distinction. Another way of looking at it, Dr. Welch, who wrote one of the books on the list there, he said, health is when we can't find anything abnormal or wrong with you. So, next. So, when we have a number or an aberrancy as a disease, normal versus abnormal, who defines the normal reference point? But regardless of how we answer this, what difference does being quote-unquote abnormal mean to how I feel or function or how long I do so? And if we keep that in mind, I really think it's going to help navigate us. This term, you're okay. This term, feeling, functioning, and longevity, that is those concepts that's referred to as patient-important outcomes. I believe that came from the NIH, but I'm not entirely sure. So we've looked at health and some definitions. We're really going to fly through this. I would encourage you to look at the extra for further resources for study for this. But I think there are some things that we can highlight as we go through these slides. I left them in the packet so that you can review them at your own leisure. There's a term, industrialized healthcare, and I think that captures what we're dealing with. It's a model that at its essence, at its core, largely, not exclusively, there is some overlap, but largely clashes at the very conceptual level with the nature of actual healthcare delivery. And that is what I've found in my experience over the years. There is a dominance of insurance companies. I think, as we know, I'm kind of shocked at how brazen they've become and are becoming, how they interfere with not just providers, but organizations and their ability to actually deliver care and get paid for it. There are a variety of agendas that you can read about. And I would also look at the punitive nature of the system with regard to providers. And I want to make a distinction here. When I'm talking about healthcare or these different aspects, I'm talking about systems. I'm not going after the intentions of particular individuals. I have an opinion of the IRS as a system that is very negative, but that doesn't mean that I think that everybody who works in the IRS is malevolent. And similarly here, we're talking about systems, or a concept of systems integrity, systems features, you know, how they operate and so forth. But really, constraints on providers and what amount to impossible expectations. I'll elaborate on that a little bit. So all of these things that I just mentioned are going to have a huge impact on our definition, or I would say our paradigm of health. What is normal and abnormal, what our goals are, what our outcomes are, how we spend our money, how we regulate. You see how important it is to have a core definition and that captures the essence of what we really ought to be after. Next, please. We can look briefly, and this is a very interesting point that one of my mentors made many years ago. If the predominance of clinical research as to what is or isn't studied is only driven by a potential for profit margin or profit motive versus the more pure pursuit of knowledge, we have to ask the question, what are we missing? Yeah. Just about normal human physiology and pathophysiology. That, I think, deserves a whole course, probably. Go next. I don't know what just happened. Oh, here we go. Electronic medical records. I would sum this up, and I think this captures the sentiments of a lot of people, but I know I've had 14 years of school and training to become a high-level data entry clerk, by and large. I spend hours in front of the computer. It is exhausting, it is demoralizing, it's this whole concept of moral injury. The equipment and the speeds and everything are outdated. And what are we doing? Why are we doing that? At least if we were doing it because I thought it was saving lives and so forth, that would be one thing. But much of that is to satisfy what I consider to be marginally meaningful or even malevolent metrics from Center for Medicare and Medicaid Services and others. And there are papers, I have these studies that I printed out, and there are others. They've found that, for example, in a 10-hour shift in the ER, the provider had 4,000 clicks. Now imagine if you have 1 second of unnecessary delay per click, and I am regularly looking at 3 to 5 seconds of delay per click. That adds a tremendous amount of time to your day just trying to navigate the chart. The more complex the patient, the worse it is, because you have to do what I call the data dance if you're going to be thorough. And unless you've got a photographic memory and see it once for a second, you've got to go back and look. And the other one shows similarly. Next, please.